Now we're going to talk about blood pressure. And you realize sitting in this room are the two opposite ends of medicine. We have people who look at their long-term sort of life goals and that sort of thing, and I deal with their stupid interactions. You know, if it wasn't really, if intelligence ever broke out in the country, I'm ruined. And I understand that. You know, I live on stupidity. But it is fair to say that in an intelligently well-run healthcare system, there are 3 or 4 numbers which dominate what you do. And there is no bigger number. In fact, all the diabetologists will now tell you the most important number in a diabetic is not their blood sugar, it's their what? Their blood pressure. Everybody now agrees with that. Blood pressure is the number. Cholesterol is an important number. Your height to weight ratio, your body mass ratio is the number. You're always better off being 140 pounds than being 340 pounds. Just from the crap you get from the nursing staff, you know, I mean, you do better. So let's talk about blood pressure in the acute care setting. That acute care setting, by the way, can be walking into your office or walking into the emergency department. Now, let me correct a couple of factual things which are wrong in your manual. Someone comments vital signs are required by the Joint Commission. Not all vital signs. If you read that passage, and I know I sat on the committee of the Joint that wrote the book, and it says, you shall do appropriate history, physical, and vital signs. The adjective appropriate modifies all 3 nouns. And so you don't have to do all of them. We do stupid things. Why would you take, and I'm going to ask you this in all seriousness, why would you take a temperature on a 20-year-old who's just cut their finger? Why? What's the science there? I always remember one nurse saying to me, well, it's got to be right. It's right here in the nursing manual. I said, well, that's the queen of sciences. Okay, that's this generation's Mathematica Principia. And she didn't get the reference, but that's all right. And the sort of the bottom line is we've done a lot of things by habit, which we don't know why we do it. One of those is taking vital signs, and I don't care if you take them, but remember the point I made yesterday. You never ask a question you don't want to do something with, because once they've written that number down on the chart, you are required to answer that number. And if you think I got a lot of TIA and stroke cases, I got piles like this. And if anybody here wants to challenge me on this, I'll put money down that I can't go back through your charts in your emergency department and find unanswered abnormal vital signs. Anybody here think that they don't have any of those? And I don't care where you are. I've done this at the Massachusetts General Hospital. All the big names. You know, we're not worthy. We're not worthy. It's always a good to remember you don't get any lower life insurance rates because you live in Boston. Okay? Their death rate is exactly the same as Ann Arbor, Michigan. 1 per person. That's it. That's the death rate. So my point is this. If you are doing vital signs, this is a rule. See, I'm really trying to put myself out of business here. If you're going to write down a number on that chart, understand you're going to have to answer that number at some point in time. And be very careful what you're going to do with it. Quite frankly, I think we ought to eliminate most vital signs. See, on average, we take the right number of vital signs in the country. We just take them on the wrong people. And we just need to recognize that. All right, so we don't ask a question and figure it out. If you're doing vital signs, as for screening purposes, understand that the emergency department in a country which has no organized healthcare system is not an unreasonable thing to do. Why? Because particularly in males, between the age of when they were in pediatrics to when they get gray, they frequently don't see a doctor very much, unless they have a what? A specific complaint. They don't get regular checkups. They don't care. And so in this kind of system, if you do blow up the cuff, and I'm not against that, I think that's probably a good idea, be sure and talk to them about an abnormal finding and note it on the chart. Don't blow it off. Give them a chance. By the way, we don't know what the normal blood pressure ought to be in certain disease entities. For example, no one has ever published the study on let's take men, 20 to 40, who have a sprained ankle. What should the blood pressure be? What should the pulse be? We don't know. The joke is when you look in Nelson's textbook of pediatrics and they have all these things, vital signs, respirations and stuff like that on kids, when were those taken? Sleeping children. Most kids who come into my place aren't sleeping. So what is the normal pulse rate in a kid in pain who's afraid at that moment in time? Just understand that we don't know the answer to a bunch of those questions. All right. Question number 1. Should we at least take a blood pressure correctly? Yes, we should. And everybody's study, first one is done in pediatrics, improper cuff size about half the time. They actually went around to various places and looked at the cuffs that they had. You know what? And then they matched them up to the kids and their arm diameter and all other kind of stuff. At least half the time, the cuffs were inadequate for the problem being addressed. And I'm real big on this concept of doing blood pressures in pediatric offices to pick up that group of people who early on may need a different intervention. See, then you're doing something real. This is useful stuff. Missing the otitis media, probably doesn't make any difference. Not picking up a disease entity which has a chance of killing them, that is a useful thing to do. Article number 2, again, this one's done in adults. And the rule is, this is sort of a Las Vegas rule, bigger is better. Okay, I always err on the side of using a bigger cuff as opposed to a smaller cuff. You will get a better reading. And by the way, most of our emergency departments have a standard one cuff. How often do the nurses go get the big cuff to do the pressure?
When you ask them.
When you ask them, exactly right. And there's no protocol written to say on a certain size they ought to use the bigger cuff.
They just put the cuff down on the forearm. It's not big enough.
That's right. They put it on the forearm if it's not too big. All right. What about automated blood pressures? Automated blood pressures have more variability, probably, than our ears, but understand this, at least it's reproducible with that instrument. If you have 3 different people taking the blood pressures, do you often get 3 different blood pressures? Yes, you do. Why? Because it's where our ears pick this stuff up. So automated is not always bad. The worst automated, by the way, is, I made a comment once to one of the nurses. They wheeled in this new little device. And you sit it next to the bed, and it can take the blood pressure, the pulse, the respiratory rate, the pulse ox. You know, I said to one of them, I said, you know, if we could teach that thing to smoke and eat pizza, it could be a nurse here. And the one thing about those machines is they are reproducible and they can make a record. How many people have ever heard this comment? I wrote the blood pressure and pulse on the sheet. Right? You've heard that, right? I had to write them down quickly on the sheet. Like the people in the central laundry needed that. I have to go defend people all the time who say, oh, we took it. Okay, where is it? Well, I wrote it on the sheet, you know. This is the kind of stuff we don't want. At least the automated machines can do that, so that's not so bad. In automated blood pressures, think about automated or some of these new devices we have to do temperature. How good is the ear thermometer? No. Well, it's terrible at the 2 ends. It's actually very good near the middle, which is normal. I saw one of the nurses one day going in, and she had the ear thing, and I just said to her, I said, how do you know whether you ought to put the one in the mouth or in the ear? She says, if I don't care what the temperature is, I use the ear one. I said, well, if you don't care what it is, don't take it at all. So, we've got to do that. This is the kind of craziness we've gotten into in this country. Fill in the box, and it has nothing to do with the disease process sitting in front of us. Automated blood pressures have the same problem as the ear thermometer, and that is in the normal range, they're quite good. As you get out to the ends on both sides, they're terrible, and below a pressure of 80, throw it away because they are so inaccurate. To make them accurate in the middle, they had to make some changes on that end, particularly on the low end. They're no good. So do not trust an automated blood pressure at the low end of the system. Take it manually. Do it yourself. What about position? Position counts. Okay, for those of you who've seen Zoomanity. Put your arm out. Have the arm at about the level of the heart. If you take the blood pressure with the arm down, it can change it by 20 millimeters systolically. And so if the arm is down as opposed to out, there is a significant change. Also, there's a change when you're sitting as opposed to when you're standing. Lowering the arm, Article 5, star it. Lowering the arm changes the blood pressure. And they did a very nice study here. And it really does show you those effects. And I think that, in fact, in hypertensive patients, people known to be hypertensives, the difference in systolic was 143 arm out, 166 on average arm down to the side when the patient's standing. I think that's a realistic thing. There is an article here which you do need to star. Again, I do not believe all literature is created equal. Some of it is fantastic, some of it sucks. Article 6, star it. This is the 7th report of the Joint National Committee on the Prevention, Detection, Evaluation, and Treatment of Blood Pressure. To shorten that up, it's the JNC7. I have a lot of respect for those people and what they have done and the team they brought together. These are real people, and they've asked the right set of questions. They've got a superb set of questions. By the way, JNC7 has come up with a new category. Pay attention, family practice people here, because it's this new pre-hypertension. What they say is, if your blood pressure is in the 120 over 139 range and 80 to 90 diastolically, you need to have them on a program where you're checking that. Now's the time to start the lifestyle discussion. How fat are you? What do you do? Why do you think smoking is a neat habit? This is where those discussions need to take place so you don't have people who are ruining their vessels. And it is a silent disease, and we're going to talk about that. It is silent. There's very little relationship between symptoms and blood pressure. Of course, they all come in and say, oh, I know I've got this headache, so I know my blood pressure's up. No, the blood pressure didn't cause the headache. The headache caused the blood pressure in those cases. So just don't get sucked into that way of thinking. In any event, 6 is what you got to look at. And I think in that article, systolic hypertension over 50 is more important factor than the mean arterial pressure. You all know how to calculate mean arterial pressure, right? That's what we went on for years. It's still an important number. But what they're telling you is, we always used to say, well, they got a very low diastolic, so just because they have a high systolic, their mean arterial pressure. That is true in the long run, but if you have a high systolic, you've now got that hard shot which is helping to dissect your arterial walls. So systolic hypertension should not be ignored, particularly over the age of 50. That systolic pressure spurts are helping to dissect your arteries. And I think, the way the arterial wall goes, it cannot respond, relax, particularly above the age of 50, at a certain time frame. And so systolic pressure needs to be looked at much more intensely than we did in the past. I love this comment from this article. I mean, obviously you can tell I'm in love with this one. But the coronary vascular disease, cardiac vascular disease, risk rate doubles for every 20 millimeters of systolic and every 10 millimeters of diastolic. It doubles. This is a real number. And I think that if you're going to talk to your patients about any number, about anything, It's their blood pressure. More than their weight, more than their smoking, more than their this or that. That's it. Goals. In that report, they said a good goal, adults, 50, whatever it is, below 140 over 90. That's where we'd like to keep it. They said something very important in diabetics. They didn't say whether type 1 or type 2. In diabetics, they'd like it 130 over 80, and that should be your new therapeutic goal. And are you going to make it? Not a lot of people, but you know what? You at least ought to have a target that you're going for. Because when they take the diabetics and they start at that point and move up, your longevity is again cut by 20% or 30% for every 20 you go up from there. Very interesting stuff, very good stuff. Question 2. Oh, by the way, we're going to talk in this about the myth of white coat hypertension. Everybody always said the same thing. Well, they're just upset because they're here in the emergency department. Their blood pressure went up. Well, they got their broken ankle. They got this. So what should you do then? Take their blood pressure again as they're leaving, when you've got them pain-free, or note that they ought to be seen by their doctor at their office or the nurse or whatever it is to have their blood pressure retaken, but don't assume it's due to just being in the doctor's office. The other thing which is pointed out is that when you call it white coat hypertension, what raised the blood pressure? The outflow of epinephrine. Okay, this is a catecholamine question. So that means if going to a doctor is an upsetting event, what do you think's happening every time they have an upsetting event in their life? Their blood pressure is going up. So now they're fighting with their husband. Now they're smacking their kid. Now somebody's yelling at them at work. I mean, just because you think it's from going to the doctors, no, it's any time we've kicked out more epinephrine in our lives. And there are people, and you know them, who they're epinephrine kickers, all right? They get upset easily. They turn red. They're flushed. They're going to strangle you kind of thing. Those people, when you take their blood pressure, say, oh, they're just upset at this moment. All that's crap. Those are people who are at risk like anybody else. And so this intermittent white coat hypertension is a myth. If they, the book paraphrases, a rose is a rose is a rose. Blood pressure is blood pressure is blood pressure. And an elevated blood pressure ought to be rechecked and followed. Do not write it off. I think that's really good. Well, let's change this right now. In the emergency department, you almost need to treat nothing, and I'll get to that in a second. But as a family practitioner, I would check them, and I'd get them a home blood pressure cuff. I mean, you can get good ones now, which are cheap, and I'd make them keep the record. And then I would decide whether I would treat them. But I'll tell you what, I am a believer in treatment in this disease, and I'm a believer in cheap medications. One other thing that commission said was we can make thiazide diuretics for 1/10 of a cent apiece. You realize that? The way we put them out, 1/10 of a cent apiece. They work. They were perfect in the 60s when I was going to medical school in the 70s. They got replaced because why? Marketing. They were too cheap. They were too cheap. They couldn't charge enough money for them. The truth is, the first drug you start anybody on in hypertension is a thiazide diuretic, hydrochlorothiazide. You can do it for damn near nothing, literally. Literally, we could build a tank car load of the crap for $100. It's unbelievable. Particularly now where they press pills and stuff like that. The actual manufacture of the pill is nothing. And this is the way we ought to be going. And they've said that straight out in their article. These are the best people in the world on hypertension said, we're not using the right drug. We're not using the correct drug. All right. What should be done with a single high blood pressure? Answer, repeat it and refer it. The emergency docs here, refer it. The family practice docs here, repeat it. Get checking that blood pressure at home. And by the way, these new ones, the automated ones, you send them home with. What are they? $35, $30? You can get a decent one now. And by the way, they're everywhere. Go to CVS Pharmacy, go to Kmart, go to Walmart, go to wherever you want to go. But these things are very easy to get. In fact, I have a family practitioner, my town. He did a bulk purchase of these things, and then he sells them out of his office at no profit, and he expects every person who's going to be in his practice to have a blood pressure cuff at home. That's a rule. He won't have anybody who doesn't have a blood pressure cuff. He says, you want to be my patient? This is what you're going to do. I like that. I like that. This is a guy who says, look, you're going to play with me? We're going to play right. And this is an important number to me, so you're going to do it. Anyway, here's a rule. Increased blood pressure rarely needs an acute intervention. IV drugs in blood pressure, and I'm from that era. How many people remember when nitroprusside came out? I mean, yeah, I am old in this room. Yeah, that's right. How many people here remember high-button shoes? You know, I understand I'm dating myself. Well, somebody ought to date me. But in any event, I understand I'm an old guy, but we were trained to be aggressive on blood pressure. It is the worst thing you can do because your body and the perfusion of your organs has now adjusted to a certain elevation, right? You do not want to rapidly lower blood pressure. You do not want to rapidly lower blood. Let's say this again and again and again. Almost no elevation of blood pressure needs rapid intervention. By the way, is it everywhere? Yes. Article 8, increased blood pressure in urban emergency departments. This again is selection bias. But they just went around, took everybody's blood pressure. Now, this is an inner city study. It's probably about a 75% black or Hispanic study, so it may not be a reflection of the U.S. as a whole, but they took everybody who came. They took 1,396 people. What were they complaining of? It didn't matter what they were complaining of. They took their blood pressure, because that's what we do, right? This is an easy study to do, because we take it on everybody. One half the patients had stage 1. That means they were in the 140 to 159 range. I won't even give you the diastolic numbers. And then you had another group in stage 2, and you had like 18 people in stage 3, 180 over 110, who didn't have any complaint that would be referable to blood pressure. This is just walking in the door. So we are the best screen in the healthcare system because eventually you will come in to see me. I do get the last laugh. See, I always love it. I had this one guy who I was treating one time, I won't even give you his name, but he was a chiropractor there in Ann Arbor. And he, of course, claimed he could treat anything. Appendicitis, migraine headache, yada, yada. You come to me and I'll readjust your spine, you're fine. And so I came in to see him, one of the residents had seen him. I came in to see him, and his first name was Ronnie, I can give you that. And I said, Ronnie, and I just felt his belly. He clearly had an appendicitis. I said, you want me to rub your back and make it better? Yeah. I see, we shouldn't even have this charade about going to the chiropractor. Does anybody have any data that says rubbing your back makes you better? See, I understand why you'd pay money to have somebody rub your front, okay? Been there and done that. I don't understand why you pay good money to have somebody rub your back. In any event, they'd be much better off having their blood pressure checked. In any event, that study, number 8, really says people walk in the door, they got high blood pressure, and they don't know it. So this is a good screen. Number 9, again, speaks to white coat hypertension, that it doesn't really exist. And what about, let's ask a couple other questions. People will say, well, I'm just taking pseudoephedrine for my cold. Now, we were all taught that that can raise your blood pressure, right? Sorry, pseudoephedrine and a bunch of this other stuff, oral stuff, stuff you spray up your nose, stuff like that, had almost no effect on the blood pressure. It was minimal at best. Do not write it off to the drug they're taking. Do something else. What symptoms should be are associated with blood pressure? That's a very good question. This is a chicken and egg question. Which came first? The blood pressure increase and the symptom, or they got symptoms and their blood pressure went up? In most cases, it's the latter. They get an increase in blood pressure because of their symptoms. Their blood pressure didn't cause the headache. And There's this huge lack of relationship, Article 13, relationship between hypertension association and increased blood pressure. This was a 2005 article by Karras, excellent, Annals of Emergency Medicine. They took 539 patients, blood pressure above 140/90, and then they just said, okay, give me your symptoms. But they didn't prompt the symptoms. They didn't suggest things like, well, you're having chest pain, aren't you? You realize that the way we ask a question decides whether the patient wants to answer it for us or against us. Patients are doctor pleasers. So if you say, it hurts in your chest, doesn't it? Or, I bet you got a little headache, right? No, never do it that way. So they just said you had to spontaneously complain. By the way, when they looked then at all the things we think are associated with headache, dizziness, blurred vision, chest pain, short of breath, there was no difference in the people who had symptoms and those who didn't, and no correlation to their blood pressure. There were just as many people whose blood pressure fell into the normal range as fell into the abnormal range with those complaints. Blood pressure, if you leave with nothing else, blood pressure is the number to follow in people. Number two, it is a silent killer. You cannot go on the symptoms. It does not tell you what the patient has. The Norwegians did the study of choice. Article 14, star it. People are always saying, well, it's my headaches. I always know when my blood pressure's up. The Norwegians did this huge study. This is a population-based study. And people with blood pressure, had slightly hypertension. They had less headaches than people who were normal tensive. How do you like them apples? In this study, hypertension was protective of headaches. Now, if you look back over the study, it's probably pretty close. The reason it rose to statistical validity may be the way they did it, but the truth is it's not the other way around. And the Norwegians did the best study I've ever seen of this. There's no support for a relationship between certain symptoms and your headache. By the way, interarm differences, at 10, a lot of people have interarm differences of 10. Don't worry about it. But what you should do if you're a family practitioner is note which arm you do and use the same arm. Always use the higher arm. If you have an interarm differences of 20 in asymptomatic people, it probably makes no difference. You have an interarm difference of 20 with people with chest pain, then I would pay attention to that. That's a problem. The study of choice here is 17, which looked at that. What about hemiplegia? There's a mistake in this chapter. What's the mistake? They said, well, maybe because he's hemiplegic, he's got less tone in that arm. What happens in hemiplegia? Tone go up or does it go down? Come on, guys. If you've had a stroke, does that arm have more tone or less? It's hypertonic. They have arms like this. They're not flaccid. They have reflexes that go like that, right? Because they've been cut off from central control. It didn't make any difference in this study whether they had a stroke in that arm or they did. They checked both sides. The arm which is no longer moving has no greater chance of a high or low blood pressure than the other arm. So don't worry about that. Take it on the most convenient arm possible, and if that happens to be the one that doesn't have feeling in it, it's even better. Why not do it? When should you treat increased blood pressure? Here's the rule now. If they have end organ damage going on in front of you, then you may do gentle lowering of the pressure. What do I mean end organ damage? You have a woman who's in eclampsia. I would give the mag. Not so much for the seizure, but it does actually give some vasodilatation, helps to drop the blood pressure. But danger, danger, danger. Rapid lowering of blood pressure has nowhere to go. It's bad, it's wrong, and it precipitates strokes. Papilledema, pulmonary edema, renal failure, and hypertensive encephalopathy should be treated, but gently. What does that mean? There's a very good article here on stroke, Article 20. By the way, star Article 19, or 19, rather 20, and listen to this carefully. The guy who's head of cardiology wrote an article and said, "This putting nifedipine." How many people have put nifedipine under the tongue?
In the last 10 years? Or ever?
Ever in your life? Yeah, we all did it. There's no way to control this, and there's very good data to suggest that we've stroked people out and cut off supply to end organs with this. That's gone now, folks. Nobody's puncturing the capsule and sticking it under the tongue anymore. Nitroprusside is just about gone. I mean, I suppose there's a bottle in the cupboard somewhere. We just don't know what to do with it. So what you want to do is much lower. You want to basically lower them through the vein, but with much gentler medications. What's the matter with using a small amount of beta blocker and see what happens? Particularly something like low pressor or something like that. You can give a little bit, watch, give a little bit, watch. And if they're having a stroke, you don't want to drop it. Let me tell you the joke of the NINS trial, or in the package that comes with TPA. They say, lower their blood pressure and then give them the medication, right? You realize there isn't one study in the literature that says that that works. Not one. No experimental evidence whatsoever, and it's an exact contraindication to what all the strokeologists say now about lowering blood pressure. Why would we do that? There is no data to suggest that the rapid lowering of blood pressure allows you to give TPA. None, zero. And if you look here, article of choice, it looks to me like there are two studies here. One of them actually looked at the question of people, 6 people who were stroked out in an emergency department by lowering their blood pressure, basically in preparation to get TPA. 6 people, 1 emergency department. Think about that. Not very good. Article 22 is good. Last one, 23. This is the one I want you to read. I think the article by Shane, April 2003, is where we are in blood pressure in the emergency department. It says straight out, blood pressure is 160 to 179. You know, simple referral to the doc. If you want to call the doc, and this is what I do frequently, I'll say, John, you got a patient in here who's got this blood pressure. We've repeated it 3 times. He's coming to see you. You want me to start him on a little hydrochlorothiazide? Again, cheap, easy. He says, yeah, give him that. I'll see him in 5 days in the office. Why not? Why not do that? But basically what it says is 160 to 179, yeah, if they're seen in the next month, no problem. Even 180 over 110, a reasonable blood pressure there. They say, particularly asymptomatic, just send them out to be seen. The only people they talk about are potential crisis, end organ damage patients. Those patients need to be treated in the emergency department.